So, Mike, it was really a pleasure to watch you do your work. And, you know, I want to summarize now and try to emphasize the strategies and the techniques that you were demonstrating with these patients.
Sure. In any brief intervention, you want to have some motivational interviewing.
Yeah.
So we want to stick to the four main processes of motivational interviewing: engaging, focusing, evoking, and planning. And so I did a little bit of each of those with both patients. The engaging is basically starting to connect with a person, making them feel at ease, reflecting generally what they're saying to you without any sort of direction or focus, just to put them at ease and lessen their possible reluctance to be there.
And, you know, that came out so well. You could tell with the young man that he started to open up and talk more about how he was drinking and the quantities, almost as if it was, you know, and even with the young lady, she got much less defensive over time. She remained a little bit reluctant, I'd say, or a little more reluctant, but still you could tell her, even in her body language, that she was lightening up. That she was, she was engaged.
And some basic empathy reflections and acknowledging how tough things have been for them. That's a good way to get the ball rolling and engage. The second part is focusing. So you might have even heard me say, so could we focus in a little bit or zero in on this? That's where the clinician doing the brief intervention decides in his or her own mind, this is my target. This is what I'd like to get to with this person. So it is directive, as MI is, but at the same time you're asking permission, always acknowledging that person's autonomy to say no or yes to the conversation.
Yeah, and you did that many times throughout both those conversations.
Sure.
And I agree, it really seems like that's the point where you really began to be more directive. It was almost, you know, it's almost clearly like a change, a shift in how you were doing the work.
I'm glad you noticed that, and that is a tricky part of it, so you want to be careful with that. You want to tread lightly, but MI is a directive approach. And my take on it is that if you don't say to someone, here's what I'd like to talk about, here's where I'd like you to go, but that's just me, would it be okay for us to talk about it? If you don't do that to a great extent, then you do run the risk of being directive where the person remains really reluctant.
Yeah, no, you clearly asked permission, and you did it in a way that they both not only tolerated, but they seemed to want to go that direction with you.
Right. Sure. So the third step is to evoke. So evoking. What are you trying to evoke? You're trying to evoke reasons for change, their own motives or motivation to make a change, but we're trying to stay connected into the thing I focused on. So I don't want them to talk about why they're motivated to, you know, change their son's school. I want to talk about how they're motivated to reduce their drinking or to go to treatment. Yeah. And that's where you heard the readiness ruler, the scale question, and why they didn't pick a lower number. And perhaps I also asked a few times what would be important to them for changing.
And what I really saw clear of that is that the questions that you had asked on engaging them were the same themes that you brought in that you already knew were important because they were the themes that were most concerning to them coming in.
Right.
For the young man, it was really his partner. He said he even asked if she could go to treatment with him. That was one of his, and for the young woman, it was her husband and her son that seemed to be some of the compelling reasons why they were there.
Right.
And you brought those into.
Well, two things on that. I brought them in because somebody did a good screening before they came to see me, and that's a big part of brief intervention. The screening comes first, so I know that. But I also want to pick up on the cues from the patient. What are the things that are most important to them? So the young woman was talking about her husband and her son. She wasn't talking about how distressed she was that she was found passed out on the bathroom floor. So even though I mentioned it, I didn't hone in on that because that's not her main motivation. So it remains very client or patient focused in that regard.
And that is critical. So often the people that we work with believe that they need to focus on certain risks that are concerning to them, that are concerning to the health provider and not the patient.
Right.
And what we know about this work is it's really important to focus on the risks that are concerning to the patient.
That's a great point. But to our medical practitioners out there, we want to say if there is something that you feel compelled to say, you do say it. Right? Or you say, well, look, from my vantage point, here's what you should look at, I think. You know, we'll see how that plays out. But it sounds like these other things would be more motivating for you to change.
Okay. Yeah. So let's get to the fourth.
Right. The fourth is planning. Very straightforward. planning on what to do next. And the main question I ask to get that part going is, what's the next step, if any? And that phrase, people always ask me, is that phrase important? Can I shorten it and say, what's your next step? Well, no, because then you're presuming that the patient will take a next step. And I want to reinforce that person's autonomy all the way through. And I jump off of where the patient says they might want to go.
Yeah, and in both these cases, it seemed to work well enough that they both started to really talk about how they would bring down their use.
Right.
Even though they came to you a little more reluctant,
Right.
particularly the young woman. And yet she was ready to at least start to look at bringing the daily consumption into more or less risky levels.
They both were more willing at the end of that step. But what did they say first? Both of them first responded with well, you tell me. Or I'm not so sure that there's really a connection.
Right.
The 3 steps prior to that went well, but then when we got to the end, when they really feel like I got to do something now, even though I wasn't saying that, they kind of became a little more reluctant again.
Yeah.
So it's important for the practitioner to ride that out and to go back almost to an engaging strategy where you say, yeah, I get it. Who wants to have to do this? This is rough.
Work.
It's up to you, though. And I think ultimately did bring them to some willingness.
Right, so help us with this part, or help me with this part. How does that compare to what you're calling the brief negotiated interview? You know, what if I were to ask you, what steps would you say were part of the brief negotiated interview, and was it all?
Okay, and what parts were more like the MI that we discussed?
More like the MI, the 4 processes.
It's important to know that MI and the BNI, the brief negotiation interview, are different things. They're very, very different, but there's a lot of overlap as well. So with the BNI, we have 4 steps, and that was actually initially developed by Drs. Stephen Rolnick, Ed Bernstein, and Gail D'Onofrio, with whom I work now. The first step is to raise the subject and ask permission. So that's kind of our engaging step. So back in whatever it was, 95, 96, they laid out these 4 steps. That was the first one. The second one is to provide feedback, is to zero in on the main concern that the physician is having and to give some neutral feedback, non-confrontational, about the downsides of that behavior and about what our recommendation might be. And it's funny how analogous it is to the new conceptualization of MI, where you're now focusing in on something. The third step is to enhance motivation, which uses, again, the motivational strategies we talked about before, evoking the patient's own reasons for change and reflecting on those. And finally, it's to negotiate a plan. So it fits very nicely, I think.
It's very similar. And in fact, they really do seem to work well together.
Yeah.
So well together. And you pointed out, and I think it's really important to do that in the feedback part, so many of the clinicians don't give advice right away like you gave it, which was really to own what you were concerned about as a health professional,
right.
And then to also let them talk about how they receive that information.
Right. That, I think, is the key. It's not about withholding advice or recommendations. It's how you frame advice and recommendations. If I say, in my humble opinion, which you don't often hear a lot of professionals saying, but that's the way to do it.
Right.
This is what I think could happen, but that's just me. What do you think? To me, there's nothing better. If a patient responds very negatively to that, then you need to go back to your engaging strategies and reflect what she's saying more. So it's not so much that I decide now's the time for advice and I give recommendations versus in this setting I don't. It's what's the feedback the patient's giving me? Are they ready?
I'm so glad you said that too, because so many times when people hear the steps of a model, like the brief negotiation interview, they would see that they were linear and you just keep going.
Right.
And what you just said, it's more like a dance, which we talk about with MI, that the patient is giving you cues to when you maybe do still take a step back.
Absolutely.
And say, we've got to re-engage. I've got to make sure I'm not pushing you
This
too
is
much.
your toolkit of tools. You can use them all and you can mix them up. That said, we're both trainers. We know what it takes to train people in a coherent and understandable way.
Sure.
And so that does require some order, some sense to that order. But at the same time, you want to give people the flexibility to to move in, to move out, to move in and move out again.
So let me go to extremes with you now. What would happen? Both these patients were reluctant, one more than the other, but not at an extreme reluctance.
Right.
And so often it's said, my patients are much more difficult than that. So let's just talk about that case scenario. How would you, change this up if somebody was much more reluctant? If somebody said, pretty much strongly, there's no way that these kind of drinking or this substance use is affecting my life or my health.
Right.
I don't understand why my doctor sent me in here to see you at all.
Right. So there are two types of reluctance right there. One is, I don't get it. I don't see why we're even talking about this. And the other is, perhaps they've recognized some harm regarding their drinking or drug use, but they're reluctant to do something about it. I'll be fine. I'll do it later. I'll do it myself. With regard to the first, I would just stay in the feedback step of the BNI and say, well, tell me what things have troubled you, even a little bit about your use. Or hypothetically, what could happen that would ever make you say, this is enough. I got to stop. Or I got to cut back. And I think the hypothetical situations and questions are excellent for really resistant folks. For the second type, if they're saying, I'll do it on my own and I don't need treatment, a lot of clinicians fall into the trap of trying to explain why they do need treatment.
Right.
We're now in the planning stuff, so I can tell you lots of things in the plan I'd like you to have.
Selling it. They're almost like selling.
I've done the MI, now I can sell it. Well, the end game is critical. And you're still basically motivating the person or helping them motivate themselves, as it were. So in that case, I would say, well, it's good that you're saying that some change needs to happen. You're saying you want to do it on your own. We'll figure out how to do that in a moment. But tell me, why is it important that something changes? And how important is that to you? How much help might you want to have just in case it gets tough? So I always build off of whatever they say that is motivational. And reinforce it. And explore it more. Yeah.
So while we have the chance, I want to talk to you about some more specific coaching strategies when you're training people in these processes. And one of them that I brought up before to you, and I thought you had some real good responses for, is this idea of pros and cons. And what you see a lot of times, particularly in doing motivational interviewing, is that clinicians, healthcare providers are reluctant to sort of cut conversations short. When they do pros and cons lists, they're exhaustive.
Yes.
And, they let it go on for a long time. Right. They want to bring everything out and have lengthy discussions about each part of that list. And I saw you didn't really do that. So tell me about that strategy of yours.
So if I'm doing therapy with someone, which I do often, then I may get into that. But the initial reluctance to get trained in SBIRT from a lot of medical professionals is, I'm not a therapist, or I don't want to become a therapist. So we can't really go into the coaching and training of these medical professionals and give them a sense that all of these conversations are going to be that exhaustive. Because you know what happens when you do an exhaustive decisional balance is both parties are exhausted. It's too much. So what I try to do, and I want to be balanced and fair about this, but what I try to do is I tell the trainees, to, as much as you can, because MI is a directive process, to lead the conversation towards the pros of change and towards the cons of not changing. So just those two quadrants of the decisional balance, rather than to equally cover all four. Unless, and this is an important caveat, is that unless the person becomes reluctant even more, defensive, or they're saying, you're not listening to me, because there are significant downsides to my not drinking. Like the woman in the second case said, it helps me. You're taking away something that could help me.
Right.
I don't want to be insensitive, so I will reflect that. But just as soon as I can, I'm going to go back to what would be beneficial to cutting it down.
Yeah.
So people get uncomfortable about how directive this needs to be.
Yeah.
So we're not forcing something, but just as soon as you can, you want to reflect and highlight the pros of change and the cons of not changing.
Got it. I also saw you use one other technique, and you did it really nicely with the readiness ruler. In both those cases, you had the patient pick a number that represented where they stood now,
right?
Their readiness to do something. And then you started to emphasize that their number, even if it was less than 50%, was still positive.
Yeah.
it was 40%.
Right.
So it wasn't 20%, it wasn't 10%.
Right.
I remember you said that to the woman. And then you went back and asked her why it isn't 10% or 20%.
Right.
And tell me what you were drawing out from her. What was it?
Well, let's give credit where credit's due. Steve Rolnick came up with this strategy
Yeah.
years ago, and he brought it to the BNI, and it is one of the most remarkable things. Remarkable in a number of ways. People chuckle at it, they laugh at it, whether they're a trainee in an MI training or they're a patient hearing it. But if you stick with it, it's quite affirming, especially when, as I explicitly said, that's good.
Yeah.
It's good that you have something. You could have said, forget it, get out of here.
Right.
So I like to first affirm that number if I can.
Yeah.
And even if they say 1, I said, well, I appreciate your honesty. That affirmation fits.
Right.
And then I'm always more interested in what reason somebody has that may lead them to change versus the reasons why they don't want to change. And that's my basic bottom line. Can I shift the conversation with the permission of the patient towards why they might want to change? And that's a great strategy for doing that.
And those questions that you ask.
They really do that.
Did it?
Yeah. What I also like to do is once they give me a reason, I don't like to just leave it there. I'd like to say, well, how is that benefit important to you? So like when the woman in the second case said, well, my husband would be proud of me.
Yeah.
I said, well, how would that make you feel? And I think she said, that's one of the few times her face brightened, and she said, that would feel good at least for a moment. This is someone who hasn't had a moment's peace in weeks. So I think it's important to bring it back to the patient's benefit.
Yeah. And not to draw this out, but what's so nice about that is that she gets to feel even emotionally for a minute with you what it could feel like, as if it was real then.
Right.
And to prepare for really feeling that in her life.
I think that's a super important point, because often these conversations are associated with all negative feelings, because it's mostly about all the downside, all the negative consequences of what they've already done. We can't change those, but we could imagine a better future. And people sometimes get more motivated by imagining the benefits of the change.
Yeah.
And sometimes just imagining it makes them feel like they've already done some of it.
So look, Mike, one of my concerns now is that in going over it and watching it is that there's some providers that will watch these tapes and they'll go, my gosh, I could never do it like that. I shouldn't even try.
Right.
This is too hard. It's too complex. There's these steps, there are these strategies, and I can't use them like these people are using them.
Right.
And I know you didn't mean it to do like that.
We don't want to give that impression, but we do want to cover a lot of different types of professionals, people with varying degrees of interest and experience. So even though you can do MI in the BNI in a lengthy and complex process, in a dance in the way you put it, going back and forth between the strategies, you can also just take out a card that has the 4 steps on it. Make sure you're not confrontational, make sure you're engaging and compassionate, but just basically read through it, and you will get the results that we've shown we've gotten in our studies. So we have complex strategies, but we know once we get into the training room, we need to boil it down and make it easy. And the BNI is one way to make it easy.
So Mike, in healthcare settings, I'm always asked by providers, look, this is just going to take too long. And I've always want to say, it's really not going to. But let me just ask you this quite clearly. How long does it take with a protocol like the brief negotiation interview to be effective with a patient?
Right. Well, our studies demonstrate that in less than 7 minutes, 6 3/4 minutes to be exact, we can get good reductions of drinking 12 months out. So if you keep doing it the way you're doing it, without this training, without the knowledge, it may continue to take a long time. But if you follow these 4 steps, it can be as quick as 7 minutes, sometimes even quicker. Some people may take a little longer, but overall, it's very, very quick.
That's really relieving to hear.
Yeah.
Particularly as more and more doctors are being asked to embed this. And it's important that they do in these environments.
Right. I mean, people wonder, how can it work so quick? And it almost sounds too good to be true. But when you start reinforcing someone's autonomy and their right to choose whatever they want, even along with advice and direction from me, very remarkable things can happen in a brief period of time.
Nice.